People who are used to using Excel files dump a bunch of data and say, oh, look, we created a model.
We've got a term in orthopedics for that: check twice, cut once, when it comes to surgery. So I think, yes, I completely understand what you're saying. Hello, everyone. Welcome to this session where we're going to be talking to you about patient-reported outcome measures in value-based healthcare, where we are today and what the future holds. I'm delighted. I've got a couple of fantastic colleagues and friends. We've got Dr. Reem Al-Bunyan, who's the CEO for the Center for Value in Health. Reem actually wears plenty of hats, as is Amy, but we'll get through one by one. She's a clinical neurologist, practicing physician. She helps shape policy in Saudi Arabia when it comes to healthcare. And she's got a crack team of people who work in bringing value to health. She also is, Reem, correct me if I'm wrong, you're the executive director for the Global Innovation Hub.
Yes.
And she has been the co-chair for the G20 when Saudi Arabia had the presidency. So yes, plenty of hats. I'm not quite sure how you do it, but thank you very much for being on this podcast.
Delighted to be here.
On the other side, in another desert far, far away, we've got Dr. Amy Sizik. She is an adjunct assistant professor of population health sciences and also of orthopedic surgery. Amy also wears plenty of hats. She works at the intersection of health economics and outcomes measurement. She's currently the co-chair of the PROMs Health Organization and helping to set up their global conference. How's that going, Amy?
Well, busy, 2 weeks away.
Fantastic. So firstly, I want to thank both of you for being here. Believe me when I say this, when it comes to value-based healthcare and PROMs, they are the bee's knees. And we're going to have a fantastic program where we're going to unpack a lot of terms, methodologies. But what we're looking for essentially is at a population-wide level, how can we use PROMs to impact patient care from a perspective of patient's perspective, the hospitals, payers, and then when it comes to yourself as regulators, how you're going to be able to shape this whole thing. So before we get started and start looking into each of these things, I'd like to ask you, Reem, how did you fall into VBC? I mean, where did that come from?
Thank you for the question, and it warms the audience to the topic. As a frontline clinician and a clinical leader, I led a neurosciences center where I was in a tertiary care center. In fact, I'm still at that tertiary care center, and we, as part of our scope of work, we took care of only people with tertiary care problems. And people that get better or people that don't need tertiary care are simply outside the walls of this entity. And in that role, I realized that, that was kind of an artificial wall, and that the boundaries need to, we need to expand and have a continuum, keeping the person's perspective, the beneficiary's perspective in mind. Because even if they're still not done with their tertiary care problem, they might have, diabetes or, other chronic conditions where they need care in other parts of the ecosystem. So that kind of started me into a collaborative, a clinical collaborative in the region. And then Vision 2030 in Saudi Arabia started. And I was invited to be part of the National Health Sector Transformation Program because of some of these ideas that relate to the care of people with chronic conditions. As we started those implementations, which is relevant to today's conversation, I realized that a central and core element of these the efforts that are happening, whether at the frontline clinician level or the organizational provider level or other elements of the ecosystem, there needs to be alignment around what needs to happen, which is deliver better value in health and care. And that was kind of the seed for getting into establishment of this think tank that is an accelerator, a catalyst in the Saudi ecosystem that also addresses some of the core concepts, which some of them we'll be discussing today, some of the core concepts of like what is value, how do we measure value, How do we express it in the Arabic language? What needs to be measured? How is it going to be measured, and things like that.
So it wasn't one eureka moment. It was more of a journey, and then you landed where you are.
Yes.
Because you're currently the Center for Value is really driving change in the kingdom, and for a lot of us who are working here, we understand the pace at which things are moving, but it's quite hard to comprehend for a lot of healthcare systems because of the rapid acceleration that is happening in Saudi Arabia currently.
Yes. And then, of course, the topic is complex. I mean, this change, globally, and I'm sure, Amy, you'd agree with this, and curious to hear about the US experience in this. It's a complex, it's a new movement, it's a paradigm shift, and it's, all health systems around the globe are trying to
adopt this.
Yes.
Let's see if there was much success elsewhere. We'll find out as we go along. What about yourself, Amy? How did you dive down this rabbit hole of PROMs?
So just like Reem, it's been a journey. I started using outcome measurement in orthopedic surgery. We would do clinical trials and prospective research studies and need to measure outcomes, especially for orthopedic surgery when, it is really patient reported on how they're doing after surgery for function and pain. And then I went and got my PhD and was training in health economics. And obviously, for those very familiar with the field, we have the incremental cost effectiveness ratio, and we have a numerator and we have a denominator, and the numerator is cost, and that denominator is some sort of outcome measurement, whether it be a quality adjusted life year. Or I said, well, wait a minute, what about these PROMs? Where is the role for those in doing essentially value-based healthcare before we were really using the term value-based healthcare? So I think for me, and then again, I do a lot of trial work and research studies, but kind of that journey of then getting back into the weeds of using PROMs and then thinking about it more globally from a value-based perspective. Again, using these measures to inform how we better distribute resources across society. As much as we'd like to think healthcare, we can just treat everyone. We can't at every time. And so how do we best use these type of measures to help us know what's really working for patients in a cost-effective way?
It's interesting because when it comes to PROMs, I've had a love-hate relationship with PROMs for a while. I think I mentioned this to you. When we were in training, I hated PROMs because they were clunky. You had to use spreadsheets and manual questionnaires. A few years ago, I heard Judy Baumhier speaking at a conference in Chicago, and it was a light bulb moment. I was like, wow, this can be done. Got down that rabbit hole. Are there any influences when it comes to value-based healthcare, people that you've sort of worked with who really shaped the way you've driven change in Saudi, and for yourself, Amy, with the PROMs world? Reem, you can go first.
I don't know that I've had the same kind of light bulb moment that you describe. I think it was a lot of it was a series of questions, and I was humbled to hear about other health systems' experience before even getting into leading the Value and Health Center. I think that was one of the things that stimulated me to be involved in this, is that this is an area where there are many questions, and health and care are very local. And it stimulated me to be part of answering those questions. You speak about PROMs in terms of the questionnaires, and we'll get into some of this as we go forward in the conversation. Maybe the future is going to be different than these long, lengthy questionnaires. Correct. And I would definitely, with my team, want to be part of writing the story.
Fantastic. Well, I'm sure the way things have headed so far, you're definitely going to be championing this moving forward. So we're talking about VBC and we're talking about PROMs, the role of PROMs in VBC. So I thought, as a scene setting, let's try to understand, if I asked you, given the expertise you have in VBC, in a nutshell, if you had to explain to our viewers, what is value-based care? Literally.
I think, that question is a fundamental and crucial question, and glad that we're starting with it as a scene setting. And the understanding of what value means, especially in a setting, in our case, the Saudi national setting, and centering around that common understanding of what it means is crucial to anything that comes after it. So value is the realizing the best possible outcomes matter the most for receiving care or healthy people in the population in relation to the resources that are invested in realizing. On a national level, we defined it, this core sort of balance of outcomes and resources is a core for any health system's definition of what value means, whether it's in the Porter model, whether it's European Union definition. In our case, the national definition, drew on a couple of national resources, like the Basic Law of Governance, where there's an article that outlines the right for health, the right for public health, and an article that addresses the right for health care, and the political commitment to universal health coverage and the way the system is designed to cater for everyone holistically and people on the individual. The other thing that we looked at is the national context in terms of what the society looks like. We are a very spiritual society with strong beliefs in the Islamic religion and strong family ties when it comes to societal behaviors and the way the society is designed in terms of caring for each other and all of that. And so we produce this national definition that includes three perspectives. Personal perspective, which is, I think, in every definition, what is important to me as a beneficiary when I'm healthy, or what is important to me when I get sick. The population perspective, the holistic, everyone's perspective, and then an additional perspective, which is the immediate community, which includes the family and immediate community in terms of, the burden of illness. When illness happens, or
it's shared across family and friends,
but also the opportunities. I mean, when it comes to resources, when you have companion with an inpatient, you have kind of an extension of the nursing care, or someone that is with the individual when they're in the hospital that would do feeding, push the button in case there's pain or things like that. So that touches on both elements of the value equation.
That's interesting. Amy, do you think in the West there's that third element of family being brought in? Is that a community rather?
Yeah, let me make sure I understand the question. So the idea of bringing family or caregivers into the value-based equation?
And the wider community, yes. Because that's quite interesting. I've not heard that before elsewhere.
I would say yes, that's becoming more and more important. We have a funder called PCORI, the Patient-Centered Outcomes Research Institute, that was part of one of our healthcare bills that was passed. And the idea was that we needed to do better research to engage, using patients and having patients determine what the research agenda should be. So what matters to patients, but two, with that, engaging family members as well who are caring for people. And especially as you think about, I think it's becoming more important even within orthopedic surgery as we are moving patients into outpatient centers and not doing things in the hospital. We're relying more on caregivers. So I agree that the value part of the equation should include holistically the care team, and that can be who's helping care for people. We also currently do have a project in rural trauma where we are engaging the caregivers to give us, what are their struggles as people are recovering from trauma. So I think it's great that was brought up. And there is a movement to measure caregivers' outcomes, right? So not only do we have patient-reported outcome measures, but caregiver measures. And that's been widely done in the TBI and the traumatic brain injury, where there's a heavy caregiving burden. And so we do have the promise measures we will talk more about.
So if I get this right, as you rightly said, value-based care is the outcomes, the best possible value demonstrated by robust outcomes against the amount of resources or cost that is being involved. Now, if I ask Amy this one, how does PROMs fit into this VBC puzzle, so to speak?
Yeah, well, I mean, literally it fits in that we do have PROMs that are also used as
I'd like you to say right at the center as the heart, but go on.
as preference-based measures, which can give us QALYs. So PROMs can be several of our PROM systems proper, the promise quality preference-based measure. We have things like the HUE or the EQ5D that I think many people are familiar with. All of those are actually PROMs that can then be used to do value-based work because we can get the preference-based measures. So we can give patients feedback in terms of how they're doing on those measurement systems, but we can also use them to calculate quality adjusted life years and put those into a literal value equation. That's what's drawn me to these measures is that they can be utilized for multiple things.
A lot of people, including healthcare, sorry, I lost you there. A lot of people get confused with is PREMs. So you've got PROMs and you've got PREMs. We understand that PROMs essentially are looking at the health status of a patient and demonstrating that, whilst PREMs is the experience to a patient journey. Have you come across a lot of confusion when it comes to these two terms bandied about, even at policy making level, clinician or patient level? Patients get it, by the way, but healthcare providers tend to get confused and muddled up particularly in certain health systems where these are reasonably new concepts. Have you sort of noticed that?
Yeah, I mean, in our setting, it's all new, and I want to build on what Amy just said. So our view is that patient-reported outcomes are broad. It's a broad umbrella that includes under it patient-reported experiences, patient-reported outcomes, some health metrics. At the population level, health metrics and other. The movement to measuring patient-reported outcomes is new, and it's catching a lot of people, as you mentioned that in your own experience. A lot of times when a frontline clinician is trained to use them, it stays with them. They don't know how to practice without them. In the case of the classic trained soon, hopefully will be old school, and also the way patient-reported experiences and generally experiences are collected at the level of the organization, oftentimes not stratified based on population segments, based on the clinician himself or herself, oftentimes not used in the clinical setting in the way to improve value as we're speaking about it. Basically, we would like to improve people's health and care utilizing these tools
as best as possible. Because recently there was, I'm not sure if you came across this article in the New England Journal of Medicine, which surveyed patients asking them whether you prefer PROMs or PREMs. Either of you, did you come across that, Amy?
I was going to say, I think there's less confusion globally within the United States of PROMs and PREMs and more with PROMs and PROs. So I agree. I think of PROs as an umbrella term, patient-reported outcomes. And then within that, I think of PROMs being these validated measures that are used to assess outcomes. And then PREMs, I think what's helped at least relieve some of the confusion. To me, PREMs have always been done by a third party in the US, right? So PREMs can think of more of the Press Ganey style where, we're asking people, was your physician, kind to you? How was the parking? Could you get there? How was the food in the hospital? So I do think there's, and a third party person would call you. They were not really related to the hospital. Now people get email. So I think that's helped to make the distinction. Where the confusion is within, at least on the US side, I can speak to is this idea of outcomes or a PRO versus a PROM. And that has come up a lot as we have asked, people have asked for things to be built clinically within our EHR. And they're really asking for a patient health questionnaire or a comorbidity screening. And people are labeling those as PROs and conflating it then with an instrument that's validated, such as a PROMs measure.
So in response to, so 83% of patients actually said they value PROMs more than PREMs. Now, this is not actually saying PREMs or PROMs, which one, but from the patient's perspective, they're more interested, understandably, in did they get a good outcome out of their surgery or their medication or their treatment, whether it's chronic conditions. Which brings us to potentially the next interesting chunk we've got to sort of look into, which is what kind of PROMs instruments should we be using? So if you look at what is an ideal PROM tool, it's meant to be validated, patient-centric, flexible, and easy to use, and not have a ceiling effect, so to speak. So if we want to sort of pick out each of those terms and talk, validation is a big thing, right, Reem? Particularly now that we're beginning to adopt PROMs in languages in Arabic or elsewhere, when we have traditionally used, this has been used in the English. So do you want to touch upon why it's important to validate these and what your thoughts are on this?
Yeah, so I think, for any tool, especially when we're speaking about PROMs and PREMs, because they touch the beneficiary direct, they have to be in the language they understand, not just the translation that has to be translated and valid. Now, we view that there are two levels. There's one level that is highly specialized. So it's, a procedure that is highly specialized. Today we're speaking about orthopedics. It could be like a type of joint replacement or a type of care for a specific orthopedic issue that will be heavily informed by the professional society and the group that is in the local setting. And they have to inform on the suitability of the tool in general, for the
use of that,
local and regional context, and then it has to be properly translated and validated and tested. And then on the other level, which is the level that we're working a lot in on a national level, we're very concerned about translation, validation, localization, and also more the ability for us to understand what's happening in
the ecosystem.
And so variation in using too many tools will make it extremely difficult to compare provider to provider, or one condition to another, one region to another region. Now, I would like to make more comments on that, because we at the Value and Health Center have not yet made a definitive policy recommendation on this. But we do think that this is a field that's evolving, and we should really stay focused on why we're measuring this. You spoke about the opinion of the beneficiaries on this. The beneficiary really wants to see the doctor or the nurse or the care team using this tool. I'm in pain.
True.
Pay attention. Or I have the most important thing to me is mobility, or I'm emotionally distressed. Or when the tool is used to make the decisions at the frontline level, that's when we are using it truly to deliver better value. And to really stay focused on that, rather than measurement for the sake of measurement, but measurement for the sake of improvement. Similarly, on a national level, or our meso or macro level, the same focus has to be in place, realizing that globally there's evolution in the tools. I think AI is going to enable us to read more how what an individual considers more important to them, and what an individual thinks is a good outcome after a procedure or
episode. That's interesting, because we'll come to AI in a bit, because there seems to be a lot of buzz about the machines taking over. But I think it's, as you rightly said, that tool which we use has to be, it's second nature now, because as a physician, we tend to sometimes rely on, and I've mentioned this before, we use investigations or imaging, complex terminology as crutches, and use that as an outcome, as opposed to what the patient actually is telling us. And that's where PROMs sort of really opens up and provides us a common language, so to speak. There's no complex terminology being used. It's a symptom. Is it pain? Is it fatigue? Can we give a quantifiable number to that? And then we're both speaking the common language as a physician and as a patient. Doctors or healthcare providers at a micro and meso level, we can't really hide. The outcomes are there for everyone to see.
But I'd like to, you reminded me to make sure that I mention something. There are, of course, really important clinical outcomes or quality metrics that have to be measured. And they're usually, I mean, you know, we always say that classic healthcare is measured. A surgeon does the surgery and then they say,
we mark our own homework.
Yes. I mean, let's be humble and let's remember that some of these metrics are extremely important. Wound infection, average length of stay, you know, these are clinical and quality metrics that must be recorded. They're often recorded by the provider. They indicate like how, you know, efficient a hospital is or how effective, you know, the teamwork is in an organization. They must be used in terms of how we measure performance. But the outcomes that matter the most are the ones
telling us.
That yes,
absolutely.
And oftentimes, you know, you may not measure it at the time you do the surgery or at the time you provide the care. They may be measured at.
Amy, do you have anything to add to that? I mean, I think we'll pick on the ceiling effect when we get to the types of metrics that we use and instruments we use and things to that effect. But patient-centric, you know, we talk a lot about PROMs have to be patient-centric. Not every instrument is actually patient-centric, is it, as a PROMs tool?
Yeah, so to that point, and maybe it is getting a little bit into the types of tools, but I think, this idea of a common language is really important. And I think so construct validity, that is the term we use in psychometrics. You know, the thing that we say we're measuring. So is the question we're asking about somebody's physical function, and do we expect that when not only is that person answering it, but every other person answering that question, everyone's using a common language that can you walk 5 meters? Does that language translate to everyone understands, hey, you're asking me about my physical function, we're measuring someone's physical function. And we know if someone says all the time or never, that gives us an idea of their level of functionality within that question. And I think the need for the common language is what prompted some newer systems, because a lot of the legacy measures that people made out of necessity on their own, they wanted to study it, had conflated what we call domains, right? So for example, I'm very familiar with one of our spine measures where we were asking people, how does your pain interfere with your ability to walk 5 miles or 5 meters or 3 meters? And again, when a patient answers that question, we cannot distinguish whether we're asking, is their pain so bad that they cannot walk however many meters, or is it that their pain's okay, but they can't walk because their function is poor? And so I think that is the important part of making sure we select correct or right instruments that we know have been, again, this term validated, have been tested in populations, and we know the thing we're measuring is the thing we think we're measuring is the thing we're measuring.
Yeah. That's. I think you've put that better than I did. Let's switch tack slightly and look at population level. So we're still talking about PROMs instruments. I know there's a lot of work going on with Paris, where you've been sort of leading with the team here. Could you just give us an idea as to what Paris is? My understanding is that you're measuring chronic conditions in the primary care setting. Have I got that right, firstly?
Yes, and so I'll explain what Paris is. Paris is short for Patient Reported Indicator Survey. It's a new tool. It's a PROM that measures patient-reported experiences and outcomes in primary care. And it's a new tool that was developed by the OECD in collaboration with a consortium of academic and knowledge centers, where this new tool would measure two sides. It would measure the provider side and assess the provider setting, and then assess the patient-reported experiences and outcomes among adults. Mostly they're people with chronic conditions, and mostly they would have multimorbidity, but some of them, about 15%, are healthy people that come to primary care for one reason. So Saudi Arabia is participating in this survey, and we just completed the phase where we sent our data together with 20 other countries that are doing this for the first time in the world. We find this initiative, very important for the reason you touched on population level, and it's also very important because it's helping us do a comparison cross-border, which is
fantastic.
Really fantastic, unique. I know the US is participating, and many other countries. And Saudi Arabia is a non-OECD member, but we've decided to do that because of our interest in moving our health sector towards value, and we wanted to be part of this first experience.
And so for someone who's been in the PROM space, some of us have been in the PROM space, how do you square that circle? And I don't mean to put anyone in this spot. How do you square that circle of getting PROMs and PREMs together? Is that going to potentially muddy the waters, or is this a totally different tool and a different perspective on how you're measuring value?
Well, I mean, I'll give a response on what we think. So a point on Paris, it's cross-sectional. So we completed it now. And as we are in discussions in the OECD Paris Working Party, we'll decide on how frequent this tool needs. And the tool includes experience and outcome metrics. And as we go into these meetings, we see that some health systems are analyzing the experience metrics, they're extracting them and doing some analysis independent of the outcome metrics. The questionnaire is too long. It's really a long survey. It takes about 45 minutes for the patients to answer.
Okay.
In our setting, we did the surveys by phone.
And this is being delivered, so the patient's not answering them. It's sort of being delivered by an external.
Well, we've contracted with a third party that's doing the phone calls, and in our experience, we're doing them by phone. So we phone the patient, and we do the interviewer goes through the questionnaire with the patient. Some countries do it electronically. Some countries
could
paper.
You potentially would you lose the value of that survey if you section and do it in chunks across a period of time rather than a long one-off questionnaire, let's say 2 months later or
some beneficiaries, they've answered a few questions and then they've asked us to call them back.
Okay.
But I mean, I don't know
Is it going to dilute the validity of your findings if you do that?
If there's a big gap between.
Yeah.
I think it won't be. I mean, methodologically, it would change.
True. Okay.
But I think we've completed we've completed the survey, the data collection, and the OECD is going to publish the flagship report in the first quarter of 2025, where we will be able to see how countries compare with each other in various elements of the chronic condition, whether it's on person-centric care, on shared decision making, on their some health behaviors. I think there's so many insights that we can gain.
So Reem, do you think this is going to be a valuable tool, particularly at a macro level, when you're looking at measuring value?
Yes.
Okay.
I think from our perspective as a think tank, we found the experience so far to really great. We are, as you know, Rahel, we spoke about this before. We're doing another phase of data collection because our population is young. The project, the methodology includes people 45 years and older. Majority of our sample is in the 45 to 50 or 45 to, and so we are now collecting data on all adults from 18 to 45 and going to kind of do a comparison.
You could segment and see.
I think, this really will aim it, because I know that our focus today is more on the population level. This will enable payers to think more about how, what they want to cover.
Divert resources.
They will help providers think about planning what they want to do for people with chronic condition, whether it's initiatives on primary care. It will also help beneficiaries understand. I mean, we are crafting some messages, insights on, the rates of
potential actionable insights based on.
Exactly.
Interesting. I know from a PROMs perspective, we can't have a discussion, PROMs and VBC, without talking about the different kinds of instruments out there, whether you're talking of legacy versus IRTs or CATs, disease-specific versus symptom-specific. So if you just had a minute or two to explain to people, there's a ton of instruments out there, right? And for someone getting into this space, it's quite challenging. So big bucketing, if you could just explain to us the different kinds of instruments.
Sure. So I think we break them down into disease specific and generic. So disease-specific, obviously, were sets of, and when I say instruments, you could use the term questionnaire to mean an instrument. And when I say items, those are the questions that are on the instrument or the questionnaire. And so disease-specific was, if you think of things like we have the KCCQ, the Kansas City Cardiomyopathy Questionnaire, very specific questions related to the condition of cardiomyopathy and heart. And so that would be considered a disease-specific measure. And then we have generic measures. And generic measures kind of encompass this idea more of quality of life and what are the buckets of quality of life. And so there's various measurement systems. You've heard me mention PROMs several times. I'm obviously leading their scientific meetings, so I have a bias there. But those measures were designed. The National Institute of Health put a lot of money into developing those using, and also not only because they're generic, but also they were developed using a field of study called psychometrics, which typically had been in education. For those of you physicians out there, when you've had to take all your standardized testing, they were developed with the same tools as that. So we actually know that the trait we're measuring is again, back to my comment about validity. So those measures typically measure domains of health. So not only physical or mental health, but we have social health. So can you participate in your activities of daily living? And those measures measure very specific domains. PROMs measures in particular can be combined to create short forms and profiles where we measure multiple domains of health. The other nice thing about that type of measurement system is, again, because it used this field of psychometrics, they used a technique called item response theory. And because of that, we know the measurement of each question. So we can use something called computer adaptive testing. And this gets at this idea of question burden, which was already mentioned. So people can answer a question and based on their answer, get a different question depending on their level of answer. So again, back to our example of walking, if somebody says, oh, I can't walk a meter, well, we're not going to ask them if they can climb a mountain. We're going to then ask them, can they get out of bed, right? So we're going to adjust our questions based on their answer to the prior question. So again, the term disease specific and generic, and then within those, you might hear the term legacy measures. So again, in the cardiac world, the KCCQ is a legacy measure. People tend to gravitate toward that. It's a questionnaire. They know what the scores mean. But if we start talking about the macro level and population management, we can't compare people across disease conditions. And so that is the downside of using those type of instruments, is we can't do the population level work that we can when we use more generic or quality of life measures that focus on domains of health. And so I think they both
that's an interesting one.
Have components that are important. But again, we can do more population management if we use generic measures.
So I'm going to pick up on that quality of life measures because I recently read, so correct me if I'm wrong, but the FDA doesn't classify a quality of life measure as a PROM. And that was news to me. This is off the back of Caroline Turvey's paper where they just spoke, and there was an excerpt in that which says quality of life measures aren't actually PROMs.
It's a PRO.
Yes. So this is where the PRO and PROM.
So a lot of these terms, like we were talking earlier, PROM, PREM, quality of life measure, they do get conflated. And I think of things in buckets, just like we were talking about earlier. So a PROM to me is a measure that measures quality of life. You can use a PROM to measure quality of life. It would be interesting to see.
So you're going against the FDA, but that's fine. I like it that you're sticking to your guns.
Based on somebody who has studied this field, you are using this to measure the quality of somebody's life. Now, I think what people then get a little confused though, is if we're talking about quality adjusted life years, we do have to use a preference-based measure that had valuation studies, whether through standard Gamble or a VAS measurement, or again, now we have new techniques, best worst scaling, discrete choice, but those measures measure qualities, which give us the utility value to do quality adjusted life year calculations. So maybe that is the difference, is making people be very clear that just because you use a PROM, you are not going to get a utility value unless you use certain types of PROMs. Again, the EQ5D, the proper, can be both quali, give you a quali, and give you a patient score on a patient-reported outcome measure.
You live, you learn. I've learned something new today. Okay, what I'd like to do is let's sort of slightly change, pivot, and talk about what has the experience. So let's face it, PROMs have been here for donkey's years, right? And we've all used them. What are the experiences in the West? And then moving on, how can we learn from past experiences and potentially leapfrog into the future in a healthcare system like ourselves? So if we start with Amy, if you can tell me, or tell us rather, what's the uptake nationally in the US been?
I think the struggle, so I would say PROMs has been going on for, maybe we could say 15, 20 years, and then 10 years kind of really, I think, again, with the use of, or the national investment in promise, I think that kind of exploded this area. However, the uptake's been slow because it was done from a research standpoint, right? So that the development of the promise measures was very research focused. It was grant funded. And so clinicians in particular, surgeons, other, medical physicians, I think have had problems with seeing it as something other than a research tool to study outcomes in a specific research study. I think what is starting to change it for the US, or at least move it in the direction of clinical care, is now we have one of our largest EMR providers is very engaged in getting PROMs into the clinical environment. And to get it in the clinical environment anymore means to put it in the electronic health record. So I think we will see uptake increase as we see it more in the clinical encounter, in the tools that physicians use every day, which for us is the EMR.
So if we're hearing you right, you're saying that, and I think this reflects purely with our experiences and my experience as well, that we've always viewed this as a research tool, but now we are able to use this as a clinical tool, almost like a blood pressure, your vitals, so to speak. But if I'm hearing you right, it's not been phenomenal, the uptake, but there is potential for it to sort of go on an uptick, so to speak.
Yes,
is that correct?
Yes, I think it's been a slow study, and as we do more, and I think the field of implementation is also helping with this, right? This idea that we do develop tools and we have studies, and how do we get things into clinical practice? And so I think that focus, and again, I think things like PCORI and the Patient-Centered Outcomes Research Institute that's focusing on what matters to patients, I think as patients demand this type of thing too, you will see that increase in a clinician wanting to be engaged in that type of work with their patients as well.
I mean, I can speak from the perspective of UK, but I know that you've got fairly close links with Oxford and elsewhere in Europe. Any ideas as to whether they've actually go on.
I'll build on, we've engaged with all the countries that are implementing Paris. And in those discussions, we've had the opportunity to talk to them about how they're using PROMs in their ecosystem. And it's still, the uptake is not there in most ecosystems. In most situations, an academic entity would be the entity that supports their ministry or to support them with research or with the translation, validation, localization of these. On the Saudi level, I'd like to build on what Amy just said in terms of the national journey and the differences, or kind of for our audience today to draw the comparison. Our journey is that there is a health sector transformation happening. There's movement, changes. The provider model is changing, the model of care is changing, there's a new public payer, the regulator is turning into a new form of future kind of super regulator, and there is a lot of movement, and there's also a lot of excitement to be part of this journey. So we've noticed in the last short months there are many groups that are getting into this PROM space. I mean, you talk about it in PROM space. So as a think tank, we think it's amazing, but we also have something to say about it. Many groups are starting to implement PROMs, thinking that now that we're doing PROMs, we're doing value-based care, where it's no, let's think about measurement for the sake of improvement. So when it's at the frontline level, as you mentioned, Amy, it's how the patient clinician engagement happens, and how they use the findings to make decisions, revise the care plan, and do that. At the policymaker, the payer level, they are able to assess what they paid for at the macro level. And I think that is extremely important. And I'm also, curious to hear, Amy, about the experience, because there, the link of PROMs into payment models, how that's happening, because there's a lot of curiosity on how that would emerge in our
I'm so
setting.
glad you teed that up for me. It's like we planned it. Because as we were saying this, the other experience or also what we're really going to see an uptake is we finally do have one of our largest payers, Center for Medicare and Medicaid, is requiring for total joints a baseline and 1 year PROM for our total joint patients. It's starting in our inpatient population, which isn't as large anymore, but it will then be rolling into our outpatient. And so that is where you're seeing a lot of people come to the table, one from, even the meso level of hospitals who weren't engaged in this, having to do this to receive that payment, or the hospital will be at a loss. Physicians being engaged because they know that they have to get this. And so I think that is the carrot and stick analogy that has been missing really in the Western, bringing, these to the forefront is if there is money on the table or money to be lost, now we have to collect these because there will be a financial
people are beginning to
incentive
and
to
take
do it.
notice.
So I think that's the other thing you're going to see. And that's why also, though, because those decisions have been made, again, EMR providers are getting on the bandwagon too and saying, hey, we can help you with this. And so you're starting to see this little, ecosystem that when one decision maker, and again, back to a payment model, which I think is ultimately where things get driven, is now technology's coming along, hospitals are coming along, physicians are coming along. And so I think that will be the other thing is as we have, and more of these bundles and payment models, I think, are coming. I think orthopedics is where they're going to start, but we'll be seeing these elsewhere.
I'd like to, can I build on
please.
something that Amy's also mentioned? You mentioned that patients are demanding it and asking for PROMs. So kind of drawing comparisons here. In the Saudi setting, health literacy in the population is not very high. We have an extremely educated population in the formal type of education, but when it comes to health literacy, it's not very high. And their ability to engage in share, and as a frontline clinician, I treat people with MS, and I can say that when I'm in clinic, when we make the diagnosis, I have to break it into at least 2 visits. Sometimes 3 visits, because it takes time to explain, it's a condition called multiple sclerosis, and we talk a little bit about what that means, and then we say, go home, come back, bring more family members, because usually it's 1 or 2 people. Sometimes they come back with more family members and we talk more, and then we set the stage for the care plan, and it's complex in that way. And we think that will rapidly change with the national transformation efforts to improve, at least in the conditions that affect the masses,
global scale.
Diabetes, hypertension, because we have higher than other countries portion of people with diabetes and obesity. Some of these public health. So as we go forward, I think we look forward to our population demanding PROMs and to use them in shared.
It's really interesting you say that, because when we rolled it out, we had 67%, I think, uptake, and I found that quite surprising. And as you rightly say, and Amy's alluded to, it's the technology now and the digitalization which is really helping. And we know that in the Saudi population, digitalization is huge, where for someone who's come from the West, it was an eye-opener to see how tech savvy, health literacy may be an issue, but not the
digital literacy.
Yeah, so marrying it is really sort of accelerating. A quick question to you, Reem. Now, as you said, there's lots of people getting excited, or lots of stakeholders getting excited with the PROMs space. Or VBC. There's a risk that people are going to start running down different tunnels, so to speak, right? Up and run with, let's go with this. And things could potentially get dirty. So as a regulator, how do you see, when you've said, hang on, we need to sort of get people aligned, how are you trying to do this at pace? Because there's a lot of movement happening in the kingdom with the transformation.
We're a think tank, so we're not regulator, but we advise the regulator.
Yes.
As a think tank, I think we have an important role in this. And I think you were with us in a roundtable that we had where as we observed the rapid progress, we brought together teams that are already implementing PROMs, harmonize the efforts that are happening. As we go forward, we will take this further into harmonizing. We, at this moment, are in the process of advising on standardizing a small set of tools that will address the public health concerns to enable the regulator and the payer to actually look at the national scene in a way where they can do comparisons and study unwarranted variation, and then provide principles for teams that are doing more specialized, as the examples Amy gave, in the more specialized conditions that are cared for.
And we just spoke about digitalization and the rapid sort of nature with which we're all picking up. I think we spoke about machine learning at the start, or AI. Do you know of any success stories when it comes to using PROMs, health outcomes measurements, with the use of AI?
I would say we are not ahead of the curve. It's a new shiny tool for us as well. Now that we do have some PROMs in one of our larger EMRs, there is the ability to start to do that kind of work and do some modeling. I would say, my early caution with AI that I have found is this idea of data scientists, and not health data scientists, so software engineers, people who come from a computer science background, getting into the business of healthcare and using that data and treating that data like it's business data. And I would say the modeling, AI is garbage in, garbage out, right? It's a black box. The models that are formed are only as good as the data that they've been provided to form those models. And so the one concern I do have with it is,
that's quite true, actually,
kind of looking under the hood and understanding the perspective of people who have either developed models. Because, for example, I'll give you an example. I was presented a model that was being used, and they took the PROMs and they summed all of the PROMs that any one patient had over the longitudinally. So, if a patient had 5 PROMs, they sum that value. If they had 3 PROMs at various time points, they sum that value. And they said the sum PROM was somehow an indicator. And I said, well, that is meaningless data. We don't sum PROMs. That's not something a clinician can make decisions based on. And so I guess I'm a little cautionary about it, again, because now everybody with a computer who can code thinks, oh, we've got now all this healthcare data we can play with, without, those of us who have PhDs in quantitative science, where we have biostatistical training and we understand demographics, and we have all these statistical techniques that we've all been very well trained to do. I think we get a little nervous that people who are used to using Excel files dump a bunch of data and say, oh, look, we created a model.
We've got a term in orthopedics for that: check twice, cut once, when it comes to surgery. So I think, yes, I completely understand what you're saying. We're almost at the we're coming to an end with this discussion. It's been absolutely fascinating. to me. What I'd like to understand is, and I'm going to start with you, Reem, to give us a sense of where are we and what you think are the 3 top tips to embed health outcomes measurements in the kingdom when we, as you start sort of advising regulators, payers, providers. What do you think are the 3 most crucial things that we should take into account?
Well, when it comes to the frontline clinician level, I think measuring PROMs should be part of the care cycle. It can't be something that's extra, that's done on the side and stored on the side with regards to the data and not used. It needs to be part of the care cycle. It also needs to come with a change management type of effort in order for the clinician to realize that, because when we speak about value, we're constantly thinking outcomes and resources. And so we're constantly thinking about the frontline clinician sometimes being the most cause of unnecessary testing and prescribing, whether it's surgeries or medicines or tests or otherwise. And so it needs to be embedded in part of the care cycle, needs to be paired with capability building element. And also the data that's produced needs to be used for the purpose of improvement, decision-making, improvement at the macro level in terms of like thinking about how it's used, like in the US experience when it comes to funding. I think that's where...
I think absolutely, because from what I'm hearing, you're saying use it in real time to ensure engagement is there for patients and physicians, using it as an actual clinical tool, and then use each of those discrete data points to be able to provide macro data for healthcare policy initiatives. Okay, that's great. Amy, from your perspective, anything else before we wrap up? What you've heard what Reem's said. Anything additional which should be taken into account as we build to scale at a national level?
When you think of scale, I think measurement selection is so important, and thinking not within just one clinical area, but again, if you're doing population management, if you're thinking nationally, again, thinking more about domain measurements and the domains of health that you want to manage across the population. So that's probably my biggest takeaway is don't, I use the term pigeonhole. I don't know if that translates well, but the idea of limiting yourself to a measurement tool that cannot be widely used and is easily accessible.
Great. So it's been fantastic discussing PROMs. We can go on forever, but I think we've got to sort of wrap up on this. I'd like to thank Reem and Amy for an absolutely fantastic eye-opening session on how we're going to sort of look at PROMs, build on the future at scale. And hopefully, if you've got any questions, any burning questions from the discussion we've just had, get in touch with us. We'll sort of point you towards the experts and take it from there. Thank you very much, both of you, and thank you for listening to us.
Thank you very much.